Hi, good night, everyone. My name is Dr. Stefan Ramrup, and today I'll be presenting on cerebral autoregulation, Monro-Kellie doctrine, and ICP monitoring, and tying all those three things together. So I'd just like to start by defining what the learning objectives are. So one, I want to define the core concepts of what exactly do we mean by cerebral autoregulation, by the Monro-Kellie doctrine, and by intracranial pressure. Second, to understand the physiology that keeps the cerebral blood flow constant despite having fluctuations. Third, to recognize what happens when those mechanisms break down. And fourth, to interpret ICP monitoring, when we do it, and what are the complications of it and the different devices we can use for it. So firstly, with the concept of cerebral autoregulation is defined as the brain's ability to maintain a relatively constant cerebral blood flow despite changes in the systemic blood pressure, the MAP, or the intracranial pressure, the ICP. It's the brain's own way of keeping the internal pressure stable by providing a stable supply of oxygen and glucose to the neurons while preventing both ischemia and swelling. So typically, this works well when the MAP is between 50 to 150. Below and above that is when you start to get ischemia or hyperemia and vasogenic edema. Just wanted to highlight the normal ICP values as well. So typically in adults, it's normally 10 to 15, and it's less in children, infants, and premature infants as well too. So when you talk about autoregulation, you have to talk about the autoregulatory curve that relates to it. So on this curve, what you can see on the x-axis is your cerebral perfusion pressure, and on the y-axis you have your on the x-axis you have your MAP, mean arterial pressure, and on your y-axis you have your cerebral blood flow. In the middle section, between about 50 and 150 millimeters of mercury, the line is flat. That flat portion represents the range where autoregulation works. So here, the blood vessels are constantly adjusting their tone to keep the flow steady, even if you have systemic blood pressure changes. But if it falls below about 50, those vessels are already maximally dilated and they can't open further, and that could result in decreased cerebral blood flow, leading to ischemia. And on the opposite end, when it exceeds 150 and the vessels are maximally constricted and can't compensate more, the flow begins to rise and that can cause hyperemia and edema. Another key thing to note is that this curve could look different depending on the patients that you're dealing with. So if you have chronic hypertensive patients, the entire curve shifts to the right, meaning that their brains are used to higher perfusion pressures, and what might be a normal CPP for someone could actually be ischemic for somebody else. When autoregulation is lost, for example, in severe TBI or diffuse brain swelling, the curve becomes a straight pressure passive line. So if you have blood flow rises and falls, you're going to have patients directly at risk from that. So the pressure would result in increased ischemia and edema throughout rapidly without the brain being able to compensate for it. So how does the brain maintain its autoregulatory states? What does it do? There is four different methods. There is myogenic, metabolic, neurogenic, and endothelial. So if you look at myogenic first, this is the vessel wall's direct mechanical response to pressure. So when arterial pressure rises, the smooth muscle in the wall stretches and they reflexively contract to prevent overdistension. And when the pressure drops, that muscle relaxes to allow more blood through, and this happens within seconds, and it's the fastest form of autoregulation by the brain. The second is metabolic. When you have increases in carbon dioxide, hydrogen ions, or conversely decreases in oxygen, that can all lead to vasodilation to increase the flow. And conversely, if you have a drop in CO2, the vessels will constrict. And that's why hyperventilating a patient actually lowers the ICP, but it also risks ischemia if overdone because of the vasoconstriction and the reduction of blood flow. The third is neurogenic control. You have sympathetic innervation from the superior cervical ganglion, and that can mildly constrict cerebral vessels. It's not a dominant player in normal physiology, but it becomes relevant if you have extreme pressure shifts, or extreme systemic pressure shifts. Then there's the endothelial mechanism, which acts through your mediators like nitric oxide and endothelin 1. And these molecules basically help fine-tune the vascular tone and interact with other systems to maintain a steady flow. So you have factors that can affect your autoregulation. We had already mentioned before carbon dioxide earlier. There's also oxygen, which, as we said, works in the opposite direction. If you have a fall in your oxygen, the brain will compensate by dilating the vessels to pull more blood in, to increase the oxygen availability to the neurons. It's protective, but it comes at the cost of raising the ICP. There's also systemic pressure and CPP. As long as the map stays between about 60 and 100, autoregulation works. But above and below that, the brain can become pressure dependent. Then you have intracranial compliance. When you have ICP rises, CPP will fall based off the equation, which we'll look at later, and your autoregulatory range will narrow. And eventually, even a small rise in the ICP can result in a drop in perfusion. You also have drugs and anesthetic agents that affect it as well too. For propofol or thiopentone, for example, that can preserve autoregulation, but you have other volatile anesthetic agents like isoflurane that can impair it, especially at higher concentrations. And then you have systemic factors such as your temperature, glucose, and your acid-base balance that can all modulate your vascular reactivity. So fever or acidosis can increase your metabolic demand, and that could blunt your autoregulatory responses. And then you have age and chronic disease shifts, which can cause the whole autoregulatory curve to go to the right, as I had said before, as in the hypertensive patients, for example, which is a chronic disease. Now, the Monro-Kellie doctrine, we talked about cerebral autoregulation, which helps maintain a stable blood flow. The Monro-Kellie doctrine basically is how the brain maintains stable pressure. So essentially what it says is the cranial vault is a rigid, non-expandable box, and the total intracranial volume is constant. That constant volume is made up of three components: 80% brain tissue, 10% blood, and 10% cerebrospinal fluid. If you were to have an increase in one of those components, say tumor, hematoma, or cerebral edema, that's going to shift your equilibrium. And then the brain will attempt to compensate for that by either displacing CSF at first or reducing venous volume. And once these compensatory reserves are exhausted, small additional volumes can result in a steep rise in intracranial pressure. The pressure-volume relationship with intracranial compliance in the Monro-Kellie doctrine now. So the key idea here is that the relationship between the intracranial volume and pressure is nonlinear. In the early phase, again, your brain can buffer the changes in volume quite well. You can add the mass, as I mentioned before, the hematoma or tumor. And your intracranial pressure can barely move, but that's the flatter part of the curve where the compliance is high. But once the mechanisms maxed out, you reach the steep parts where you can have a patient suddenly crashing. Mathematically, this can be expressed as a change in volume over the change in pressure. And what it means is a compliant brain can absorb pressure shifts and a non-compliant brain cannot. So before that critical inflection point where your brain decompensates rapidly, it has three main compensatory methods. One would be the CSF displacement. CSF is pushed from the cranial vault into the spinal subarachnoid space, and the arachnoid villi also increase CSF absorption, and production may fall slightly if your CPP drops. The secondary mechanism is your venous displacement, where your dural and cortical veins collapse a little, moving blood into the extracranial venous system. But there's only so much blood that the venous blood can, only so much blood that can be shifted across into that space. And then finally, once those reserves are used up, the brain starts to deform. Initially, just subtle changes in shape, but once the limit is reached, the tissue begins to shift from one compartment to the other, and that's where you can get herniation, brain herniation. So just clinically correlating the Monro-Kellie doctrine, let's say you had a patient with hydrocephalus, where your CSF outflow is obstructed or your absorption fails, your CSF accumulates and the volume rises. And at first, your venous blood is displaced to keep your ICP stable. But over time, the ventricles will enlarge to accommodate the extra fluid. And that's where you can get patients with chronic communicating hydrocephalus, and they have large ventricles and only modest pressure elevations because the system has compensated structurally. In contrast, a mass lesion that behaves differently. So tumors or hematomas that compress both CSF and your venous compartments, you're going to have a steep, quick rise in your ICP, given your classically raised ICP symptoms, such as your headache, your vomiting. You can get papilledema, and finally, depressed consciousness as it continues to rise. The most dramatic consequence, as I mentioned earlier, is herniation. And you have different types of brain herniation that you can see on the image on the right-hand side. So for example, in uncal herniation, the medial temporal lobe presses on the third cranial nerve, and that could be clinically seen as an ipsilateral dilated pupil and contralateral weakness from peduncle compression. You have central herniation, where you have the downward displacement of the diencephalon that could lead to bilateral pinpoint pupils, decerebrate posturing, and eventually the loss of brainstem reflexes. And there's also tonsillar herniation, which is where your cerebellar tonsils are forced through the foramen magnum, compressing the medulla, leading to respiratory arrest and death if it's not relieved. So it's very time sensitive. So now taking a look at ICP monitoring and the rationale behind it. So by definition, ICP represents the pressure exerted by brain tissue, blood, and CSF within the fixed cranial vault outlined in the Monro-Kellie doctrine. In normal adults, in normal patients, it typically ranges between 5 to 50 millimeters of mercury, and pathologically above 22 millimeters of mercury, it's considered raised. So the main reason we monitor the ICP is to catch that rise early, ideally, before it translates into secondary injury. And it helps us maintain adequate cerebral perfusion pressure, which is, as outlined below, the difference between the MAP minus the ICP. Monitoring this lets us see in real time how interventions are working. So if we hyperventilate a patient, drain CSF, or start any osmotherapy, you can confirm if it's actually lower the ICP and improve the CPP or not. What are the indications that we use for ICP monitoring in the first place? Well, the clearest evidence comes from the Brain Trauma Foundation guidelines, which recommends ICP monitoring in severe TBI, a GCS of 8 or less, when the CT shows a mass lesion, contusion, or diffuse edema. In these patients, autoregulation is typically impaired and ICP tends to fluctuate unpredictably. If the CT looks normal, you still consider monitoring if the patient has 2 or more risk factors, which would be aged over 40, systolic pressure under 90, or abnormal posturing, which can predict a high chance of raised ICP even when it's not, the mass isn't seen on scan. Beyond trauma, there are several other important contexts. So in hydrocephalus, ICP monitoring helps you understand the pressure dynamics and whether to place or adjust a shunt. In subarachnoid or intracerebral hemorrhage, it can help detect secondary hydrocephalus or worsening edema, especially when the patient's neurological exam can't be relied upon due to sedation or intubation. And it's also used in other critical situations like hepatic encephalopathy or large infarcts with malignant swelling, or even for postoperative patients following tumor or hematoma evacuation when you're worried about rebound edema. So there's many different methods that you can do to monitor a patient's ICP or intracranial pressure, starting with the intraventricular catheter or your EVD. This is considered the gold standard, and it's inserted typically through coccus point in the frontal horn of the lateral ventricle. And this catheter will connect to an external strain gauge transducer that we zero at the level of the tragus. And it gives us direct measurement of the intraventricular pressure. And importantly, it also allows for CSF drainage. So it's both diagnostic and therapeutic. It can let you send CSF analysis, or you can recalibrate the system at any point in time. Main issue with this is typically infection. Next, you have the intraparenchymal fiber optic or strain gauge probes. So your devices like the Camino or the Codman microsensor, which are quick to insert and they're accurate, and they have a much lower infection risk compared to EVDs. They measure the pressure at the tip using either optical reflection or an electronic strain gauge, and the drawback is zero drift. So over several days, the sensor baseline can slowly shift, so you can't recalibrate it once it's in. You have your subdural and epidural sensors, which were popular for years ago, but now they're mainly used for postoperative trend monitoring. They're minimally invasive, but not very precise, so they often under-read true ICP by a few millimeters, which is quite important in ICP monitoring. Then you have lumbar pressure monitoring, which is reserved for communicating hydrocephalus or idiopathic intracranial hypertension. It is contraindicated, however, if there's any intracranial mass or obstructed CSF pathway, because lowering your spinal pressure can precipitate a cerebral tonsil herniation. But the main takeaway point here is that EVDs are currently the gold standard accuracy and also a therapeutic option as well. This image basically just shows you how the different probes look. So you can see one placed in the subarachnoid space, I would be placed into the ventricles or the lateral ventricle in the epidural space, and then intraparenchymal as well too. So when you're looking at ICP, when you're doing ICP monitoring, you have different waveforms that you have to look at. So the ICP trace mirrors the cardiac cycle. So the first one is your P1 or your percussion wave. It represents the transmission of the arterial pulse from the choral plexus into the CSF. And in a healthy, compliant brain, P1 is the tallest wave. Next is your P2 or your tidal wave, which reflects the brain's compliance, how much it can stretch and accommodate that pulse. And as your compliance worsens, the P2 rises and it can even surpass P1. So if you see a P2 greater than P1, that can be an early warning sign that your intracranial compliance is dropping. Then you have your P3 or your dicrotic wave, which follows the closure of the aortic valve and venous outflow. And it's the smallest of the three. Typically, what you want to see is P1 greater than P2 greater than P3, which would translate to everything being fine and there being good compliance. If you see a P2 being greater than a P1, your compliance is reduced and you should watch closely. And if you have a flat trace, for example, either your patient's circulation has collapsed or your probe is just blocked. This just outlines what I just mentioned. You also have pathological intracranial pressure waves or your Lundberg waves. These are larger, slower oscillations in the ICP, and these are the Lundberg waves, which was named after Niels Lundberg, who first described them in the 1960s. And they come in three types: your A, B, and C waves. Your A waves or your plateau waves are the most serious. The ICP suddenly shoots up, often by 50 to 100 millimeters of mercury, and it stays elevated for several minutes before dropping back down. They can be caused by vicious cycles of vasodilation and loss of compliance. And then you have your B waves, which are smaller rhythmic oscillations that are around 20 to 50 millimeters in amplitude, and they occur about 1 or 2 times per minute. And they represent vasomotor instability and an early reduction in compliance. And you could often see them during REM sleep or a precursor to A waves in deteriorating patients. And then you have C waves, which are small, high frequency oscillations, about 2 to 5 millimeters. And these are normal and they're related to Maya waves, which reflect cyclic changes in your arterial blood pressure. You also have secondary monitoring parameters as well too. Most fundamental one being one we mentioned before, your cerebral perfusion pressure, calculated as your MAP minus your ICP. It is the driving force for your cerebral blood flow. And for most adults, we aim for 60 to 70 millimeters of mercury, as recommended by the Brain Trauma Foundation. Below 50, you risk ischemia. Above 80, you risk hyperemia and edema. Next is the pressure reactivity index, which correlates slow waves of MAP and ICP. If your autoregulation is intact, an increase in MAP leads to vasoconstriction and a decrease in ICP, which is a negative correlation. If the autoregulation is impaired, the MAP and the ICP move together, which is a positive correlation, meaning that the brain is pressure passive at that point in time. Then there's PbTO2, brain tissue oxygen tension, which is measured with Lycox probes. When measuring with this, you aim to keep it above 20 millimeters of mercury. A drop below that could suggest local hypoxia or ischemia. And it's useful in diffuse TBI, where your regional perfusion can vary. Then you have your jugular venous oxygen saturation, or your SjVO2, which tells you the balance between oxygen supply and demand. If this were to drop below 55%, your cerebral extraction is high, which can mean that there's global hyperperfusion and your brain neurons are extracting as much oxygen as possible. If it climbs above 75%, then the brain might be hyperemic, or the mitochondria are failing to use the oxygen that it has available efficiently. And then you have cerebral microdialysis, which measures your lactate, pyruvate, glucose, and glutamate in your extracellular space. And a high lactate to pyruvate ratio can indicate a metabolic crisis, often before you even see an ICP or CPP change. We mentioned the different types of ICP monitoring devices, but they have different sorts of complications depending on which one you're using. The most common and important one is infection, particularly a ventriculitis. The risk is longer, the catheter stays in. So typically around 5 to 50% after 5 days. And main thing here is prevention. So it's important you keep a aseptic technique, a closed drainage system, and whenever possible, you use antibiotic impregnated catheters. Second, would be hemorrhage. So inserting a catheter through brain tissue always carries the risk of causing a tract bleed, about 1 to 2% chance. It's uncommon, but more likely if the patient is coagulopathic or hypertensive. And using image guidance or neuronav can reduce that risk. Then there are mechanical problems. So catheters can become blocked by debris or brain tissue, or they can be malpositioned against the ventricle wall. You'll see this when your ICP trace flattens or behaves inconsistently. Then we have pressure-related complications. So the classic one will be overdrainage. If your CSF drains too quickly, the ventricles can collapse, stretching the bridging veins and even leading to subdural hygromas or downward herniation. To prevent this, you always want to set your EVD height correctly and make sure that it's still at the correct height. You want to drain gradually and never leave the system to open to free flow. And then for intraparenchymal probes, there's the issue of the central drift that we mentioned before. So with all this said, how do we manage raised ICP? So we can look at the Brain Trauma Foundation guidelines on how to do this. So for adults with severe TBI, we treat sustained ICP above 22 millimeters of mercury, and we want to target a CPP between 60 and 70 millimeters of mercury. To protect that CPP, we keep age-based systolic blood pressure floors at equal to or greater than 110 if the patient is under 50 or over 70, and equal to or greater than 100 for patients 50 to 69 years of age. So the Brain Trauma Foundation guidelines is a tiered protocol. So in tier 1, it's your protection basic. So you want to keep your head up, 30 to 45 degrees, neck in the midline, good sedation to stop any coughing or vent asynchrony. You want to keep the patient normothermic. You want to use isotonic fluids and ventilator settings that will keep the PaCO2 between 35 to 40. At the same time, we actively want to maintain the systolic blood pressure at a range that will allow the CPP to stay between 60 to 70. We're doing that based off of our equation. If the ICP still remains high, your tier 2 would be to add CSF drainage with an EVD when possible, plus hypoosmolar therapy, so mannitol or hypertonic saline bolus. If there's any acute herniation physiology, we can briefly hyperventilate as well too in this tier 2 to a PaCO2 of 30 to 35 as a bridge for definitive treatment. And then your tier 3 would be for refractory ICP. So you can consider a decompressive craniectomy or a barbiturate coma with the EEG. So just to wrap up the presentation, just a summary or key takeaways from this. First is to remember that cerebral autoregulation is the brain's ability to maintain a constant blood flow across a wide range of perfusion pressures. When it fails, the brain becomes pressure passive. So every blood pressure swing can translate directly into ischemia or swelling. Secondly, your Monro-Kellie doctrine tells you why the pressure rises in the first place. Inside the skull, you have the sum of the brain, blood, CSF, and it's fixed. And then earlier on, you have CSF and venous shifts to compensate. But once those reserves are used up, tiny changes can cause huge pressure rises, which is when a patient could crash. Third, ICP monitoring lets us quantify the physiology that we talked about, and we want to treat sustained ICPs above 22 millimeters of mercury, aiming for a CPP of 60 to 70, as well as pay attention to our ICP waves. And then we want to integrate this clinically by ensuring that every intervention we make targets a particular corner or a way that we can influence the blood flow to the brain. So you can either reduce intracranial volume, increase your perfusion, or stabilize your vascular tone. So with that, these are my references, and that brings me to the end of this presentation. Thank you.